Hi, this is John Schmidt with Kidney Care Partners. We're going to go ahead and get started now. Kidney Care Partners, or KCP, is a broad-based coalition of more than 30 organizations representing the chronic kidney disease and the end-stage renal disease community. Welcome, everybody, to today's KCP webinar on our PEAK program. PEAK stands for Performance, Excellence, and Accountability in Kidney Care. This is a voluntary quality initiative our community challenged ourselves with a few short years ago, and today's webinar will highlight the data results of the PEAK initiative compiled by Dr. Vince Moore of Brown University, who you'll hear from in a little bit. Before we get started, a few notes about the webinar. If you chose to dial in from your telephone, please be sure to keep your line on mute and refrain from asking any questions during the presentation. We will reserve some time at the end for some questions. If anybody has any problems or technical difficulties during this webinar, please call 703-548-0019 for assistance. That's also on the advisory that was sent out. This webinar is being recorded. The audio and video recording of the presentation and the slideshow that accompanies it will be available on the KCP website later this week. And our website is simply kidneycarepartners.com or .org. So now I'd like to turn this over to our first speaker, Dr. Ed Jones. Dr. Jones is actually the chairman-elect of Kidney Care Partners. He is a practicing nephrologist and is chief of the renal section at Chestnut Hill Hospital in Philadelphia. He's also a clinical professor of medicine at Temple University Hospital. Dr. Jones has served as the president of the Renal Physicians Association, and he represents the RPA at the American Medical Association and at Kidney Care Partners. Dr. Jones also served on the RPA, American Medical Association Physician Consortium for Performance Improvement, which is responsible for the development of physician performance measures. He is actively involved in public policy and advocacy for nephrologists and kidney patients, both at the state and national level. At this point, I'm going to turn it over to Dr. Jones. Dr. Jones.
Appreciate the comments, and thanks everyone for taking the time to sit with us and hear about a very exciting program that Kidney Care Partners initiated a number of years ago. As John mentioned, Kidney Care Partners is a unique coalition that represents all aspects of kidney care community throughout the country: patients and patient advocates, dialysis facilities and providers, physicians and nurses, and pharmaceutical companies and device manufacturers. KCP's mission is to ensure that the 1 in 9 patients with chronic kidney disease in this country receive optimal care, that these patients have a high quality of life, and of those 400,000 patients who are on dialysis, that they have ready access to their needed dialysis service. And finally, to have research and development lead to enhanced therapies and innovative products. KCP has been also unique and has been in the forefront of quality initiatives in various aspects of the community. Indeed, the PEAK program that John alluded to started in 2009 with the lofty goal of reducing first-year mortality rates. As I mentioned, we have been heavily involved with the quality initiative and formed the Kidney Care Quality Alliance in 2005. And the Alliance initiated a number of core measures for value-based purchasing and marshaled those measures through the NQF process, initially with time-limited endorsements, but subsequently full endorsements from the NQF. In September of 2008, KCP got together and pursued on a voluntary basis a national goals initiative. As many of you know, during those times, the overall mortality rate of patients have been declining over the last couple of years for those patients who've been on dialysis for more than 2 years. Unfortunately, we don't see the same pattern, or did not see the same pattern, in incident patients, particularly those in the first 90 days of dialysis. Those patients still have unacceptably high mortality rates coming into our study. And we saw at that time clear evidence, although small-scale studies, that an intensive focus in incident patients demonstrated improved survival. It was with that data and knowledge that KCP stepped up to the plate to focus on improving survival in first-year incident patients. The PEAK process developed by forming 3 expert panels, 2 of them to identify best practices, tools, and resources that could be used by the community. So we formed a patient and family engagement expert panel and a technical curriculum expert panel to accomplish that. We also formed a data results expert panel to be able to monitor the data and the results. The QIO of Rhode Island, Quality Partners of Rhode Island, now health-centric advisors, were engaged to manage the patient and technical panels, and Brown University, under the guidance of Dr. Moore, who you'll hear in a short period of time, and Swaminathan, were engaged to independently analyze the data in consultation with the data results panel. These panels put together 18 best practices, including tools and resources in the clinical and patient-family engagement, and these tools and best practices were disseminated to be used by KCP members. Those best resources, best practices can be found in our PEAK newsletter, and they're posted on our PEAK website, and we can touch base on them if you want in the question and answer period. Data results panel met on an initially monthly, subsequently quarterly basis to review renal management information system, the RMIS data analysis system. The panel redefined benchmarks of mortality rates of dialysis patients against which the campaign improvements could be gauged for both 1-year and 90-day mortality rates. In addition, the panel monitored various factors, which you'll hear about, contributing to first-year mortality, for which interventions could improve survival rates. I'm now going to pass to Dr. Moore to review the data for us. Let me first introduce Dr. Moore, who's had an extensive career. Dr. Moore is the Florence Pierce Grant University Professor of Community Health. He's been a principal investigator of over 30 NIH-funded grants focusing on organizational and healthcare delivery system factors that are associated with variations in use of health services. In 2011, he was awarded the Academy Health Distinguished Investigator Award for contributions in health services. He's held a Merit Award. He's was a member of the Secretary of HHS National Committee on Vital and Health Statistics. He's had 25 years of experience in Medicare, chronic disease management, and quality management, and has had multiple grants for multiple sources, and has had over 250 peer-reviewed articles. And it's been a pleasure to work with him on this project, and I will now turn this over to Dr. Moore. Thank you.
Several years monitoring changes in mortality in the kidney dialysis population. I'm going to move forward. So what we did was to use largely the data from the Renal Management Information System, we call REMIS. The data has been available from Centers for Medicare and Medicaid Services since the initiation of the end-stage renal disease program in 1973. And so we had all of that data available, and so we were able to look at every new patient entered into the dialysis program, and were able to then track their mortality over a 90-day period as well as over a 1-year period. The data we used for the final report, which I believe is available, is complete is current through 2013, and that is all patients admitted into dialysis through the end of December 2012 were followed through at least 90 days to have that summary period. Okay. We use a methodology for tracking mortality very similar to that which is used by the U.S. renal dialysis system, the data system that's available, except we did not replicate exactly all of the other data sources that are available because they're quite close to the data that's available just from this REMIS, from this most current information. The advantage of the REMIS data is that it's basically only 3 months behind, which means you're really right on target in terms of being able to track things, if not in real time, close to it. We were going to use Social Security death data for the report, but the data we have actually is fairly complete, and since we were looking at just changes in the over time, that gave us a constant ability to look at how mortality changed using this exact same definition and data source for mortality throughout the period of the report. So we present data, which I'll show you in just a moment, for 1 year mortality using 2 different strategies. Per person year, which is how the USRDS defines it, as well as the much simpler approach of just saying what percentage of patients died during that period. And we used exactly the same approach for 90-day mortality as well. So the final report actually incorporates some of this other information, plus we present some information on variation in network level, which is largely very geographic level of variation in mortality, as well as the differences in the kinds of treatments patients experience. But today I'll just be focusing on the mortality. So in this next slide, we see the 1 year mortality rate. It started at just under 26%. That's adjusted for all kinds of characteristics of the patients, and it dropped down to just under 22%. That's a decline of about 13.6% during that time period. And if we look at basically the same simpler definition as the percent of patients who entered, who died within 1 year, it's just over 22%, drops to just under 19%, about the same 13+ percentage point decline. So in terms of the actual crude percentage of patients dying, it goes from about 22.5% to just under 19%. That's almost a 4 percentage point reduction in mortality over that period of time in 1 year, in the 1 year. Now, just briefly to go to some variation. One of the principal factors that's traditionally associated with mortality is the age. There was really no change in the age of patients who entered dialysis in the early years of the peak program and in the later years, but we still did our analyses separately by age group, and we saw that younger patients entering had a greater level of decline than did the oldest of the old. But even the 75-plus-year-old patients had almost a 13% decline in 1 year mortality. So here we look at the 90-day mortality rate, and you can see it bounces around a little bit more. Perhaps most instructive is to look at the percent of patients dying within 90 days of entering, and that's just over 8% in 2008. To just around over 6% in the end of 2012. And so we see that's about a 22% reduction in the likelihood of dying within 90 days of initiating hemodialysis. I didn't mean to go all the way there. I meant to go, yeah, okay, here we go. Yeah, that's the next one. So by either method, whether we're looking at the rate or just the percentage, we observe about a 13+%, 13.5+% reduction in mortality in 1 year mortality, and about a 22 to 25% reduction in the 90-day mortality. Since, as we've observed it over this 4 or 5 years of monitoring this, the 90-day mortality is indicative of survival at 1 year. Obviously, there's a relationship between that. When 90-day mortality drops, you generally see that reflected in the 1 year mortality. Since we've seen a relatively large drop in the last year of observation in the 90-day mortality, we anticipate that the 1 year mortality will continue to decline, at least in the short term, because of that. Now, in our final report, we note that there are certain laboratory values like hemoglobin or albumin or other measures that indicate the frailty or the condition of the patients at the time they had entered. And by and large, there weren't a lot of changes in those parameters over the time period of observation. We did observe that there was a slight reduction in hemoglobin levels over that time period, but we conducted the analyses looking at just patients with hemoglobin levels under 12 at the time of initiation, and we saw almost identical rates of decline in mortality in that subpopulation. So there was no effect of the change in hemoglobin levels that may have occurred over that time period on the improvements in mortality. We also did note a striking reduction in this 90-day mortality, which began, as I said, during 2012. So as I mentioned before, we do anticipate this is going to be played out even more so. We also observed, particularly over the last year or two, a fairly large increase in the proportion of patients who were prescribed 4+ hours of dialysis on the machine at the time of dialysis initiation. Now, we don't know if they actually sustained that level of prescribed dose of dialysis in future months or years, but we do know that at the beginning it's an important time, and that actually increased substantially, and it corresponds with this reduction in 90-day mortality. So it gives us more reason to expect that there's going to be a further reduction in one-year mortality as well. So as I said, the final report also has information on variation in network performance. So certain parts of the country seem to have perhaps implemented features of the peak intervention more aggressively than did others, and that appears to be potentially reflected in variation in the improvements in mortality as a function of the region of the country. And that gives actually us hope that suggests that more aggressive adoption of the strategies might yield even greater improvements in the future. So I'm happy to take any questions for myself or Dr. Jones.
This is Kristen from Sydney Care Partners. At this time, we are going to go ahead and take you all off of mute. If you have any questions, please identify yourself first, and we can work through the questions for Dr. Moore and Dr. Jones. So does the sharp decline in mortality during 2012 remain if you were to include Social Security data? If not, this reduction could be due to report lagging.
So I'm assuming, this is Vince Moore, I'm assuming that question's for me, yeah?
Yes.
Okay, so we've done these analyses with and without the Social Security data. It's important to note that the Social Security about a year and a half ago made a significant change in how they're doing reporting and so on, making their data, at least that which is available that which was available at the time, less reliable than it had been. So all of the analyses we've done are using just the REMIS data, and which means that there's no change in reporting over time. So whatever reporting bias that there might be associated with those data, it's constant. So the rate of improvement we're seeing is irrespective of reporting.
Hey, thank you, Dr. Moore. Does anyone else have any questions?
You know, just to make a comment again, I think the really fascinating thing about the study is the impact on the first-year mortality rate, something that we, on the first 90 days, actually. And it's really the first time in a large number of patients has been seen, and it is clearly, you know, a voluntary use of the various protocols and best practices. But hopefully this is a sign that we'll continue to see a decrease in these rates if the tools are utilized.
So this is Vince Moore. Just one comment on that is that the most recent report from the United States Renal Data System actually has a really great summary going back to 1998 of the 6 months and 12-month mortality rate, and they were absolutely flat up until 2006, 2007, suggesting that something did change after that that was quite dramatic.
Hey, this is Mark Newman. Can you hear me?
Yeah.
Mark Newman with Nephrology News. My question is, it was noted in the summary about perhaps one of the things that may have helped with mortality is increase in the dialysis time. Is there anything else that you can tell us, and it may very well be in the report and in the tools, but anything else you can tell us in terms of what you saw as changes in practice patterns over the last couple of years that may have led to these drops in mortality? Anything else that you think that clinics did in terms of treatment that may have helped the mortality rate?
So I'm going to actually let Dr. Jones respond to that, simply because we're looking at this from 30,000 feet, looking at the data. The data aren't very granular in that sense.
Right.
This is a voluntary sort of change in practice quality improvement program. It's not a randomized trial, so we don't know exactly how much of X changed or how much of Y changed in each practice setting. So it's very difficult. The one thing we do know about the change in dialysis time is that was a pretty dramatic and large change.
Mm-hmm. Yeah, I probably don't have much more to add to that, Mark. Again, being a voluntary program, what we've not been able to do is to go out and look from individual center to individual center to see what they did. We can only look at the population of patients, and there's, when you see the report, you'll see there's a lot of geographic variability, even in, for example, catheter rates. And it may be by honing down in those areas where they showed an improvement in catheter rate, we might be able to see, an impact on mortality. But from the current design and current data, we can't say that.
Right. I mean, we know that there's a lot of variability from the networks. No matter what study you look at, there's been a lot of inconsistency among the networks in terms of quality improvement and/or performance. So I hear what you're saying. If we could look at some of the indicators that have improved in general, there might be a tie-in with mortality.
Right.
Hi, this is Lynn Poole. I have a question. Was there any way that you all could show actual use of the tools and resources? And I mean, because I'm thinking about the other changes that have happened during that time period. We have the the KDE education program, the official first activities, the QUIP program, the QUIP, all those things came into play during this time period. And is there any way to separate out what influences those things may have had, and also how the tools were utilized and where and how they were disseminated, et cetera, et cetera? Maybe you have that information. I just was curious, since it would be important to know if the results related back to the use of specific strategies and tools.
Right. I mean, that would be, I think, probably one of the more helpful things to do, but that has not been done, at least to the study to date.
So we have time for one more question. I think someone was trying to ask one earlier and their volume may have been turned down. Do we have any other questions? Okay, well, thank you so much for joining us today, and thank you to Dr. Jones and Dr. Moore for presenting today about the PEAK information. If you are looking for any additional information about the PEAK initiative, you can visit the Kidney Care Partners website at kidneycarepartners.com. We will also be posting the recording of this webinar and the presentation that is included later this week. Thank you, everyone, for joining today.